really it's important to understand that it's just IBS, because the symptoms of IBS impact just as much on quality of life and social functioning as having inflammatory bowel disease. I think if you come at it from a perspective as a physician of saying, I don't know what's wrong with you, it must be IBS because it's not any of these other things, then I'd call that like the dustbin diagnosis. You're sort of, well, if all else fails, this is what it is, and it's not a big deal.
Welcome to Dr. Ruscio Radio, providing practical, science-based insights into health. We break through the bias and the noise to bring you simple, trustworthy information that matters. Hey everyone, today I spoke with Dr. Alex Ford. He came recommended from Dr. Michael Camilleri, who's over at the Mayo Clinic. Dr. Alex Ford is a researcher in IBS, and he's recently authored a meta-analysis on probiotics for IBS. A really smart, caring, and humble individual. I deeply appreciated the conversation, and now we will go to that discussion with Dr. Alex Ford. All right, so Alex Ford, welcome to the show, or I should say Dr. Alex Ford, esteemed researcher who's recently published in The Lancet, by the way. So let me start off with the congratulations.
Thanks very much, Michael. Nice to be here.
Yeah, it's great to have you. Your name came up in the conversation with Dr. Michael Camilleri, and you published a meta-analysis on probiotics. You've also published, of course, on many other things. But because your involvement in IBS, I wanted to kind of pick your brain on multiple things. So maybe you can start off by just giving us a rundown of what you've been involved in. Obviously, IBS care is a mainstay of what you're doing. But for people who haven't heard your name before or haven't read some of your papers like I have, can you give us the short on what you've been involved in?
Sure, yeah. So I predominantly do research in irritable bowel syndrome these days, IBS, but I started doing research when I was a younger man into Helicobacter pylori and dyspepsia. I kind of switched tracks when I did a fellowship at McMaster in Canada and started doing evidence-based medicine and evidence synthesis in IBS. And that's led on to kind of an interest in the epidemiology of IBS and other disorders of gut-brain interaction, and how to diagnose these sorts of conditions as well as how to treat them, mainly via meta-analysis, but also randomized controlled trials in IBS as well.
Right. And on the show in the past, we've really harped on how important it is to look at randomized control trials and synthesis of those via meta-analyses. And I've also tried to be careful to say that's not going to give you everything about everything, but it's a very important starting point. Meaning there's some areas where we don't have a lot of research, so we have to do our best guess or make the best recommendation when there's a lack of data. But certainly for many components of IBS, there's a wealth of research, and so we should use that to help us guide recommendations that we make. One of the things that we can start with is kind of how we define IBS, because this has shifted a little bit. And I think this is an important point to make, which now the definition is more flavoring the gut-brain axis or gut-brain interactions. So do you maybe want to tell us a little bit about how the thinking and the diagnosis of IBS has been updated?
Yeah, that's a great place to start. So I guess we've moved away from the concept of IBS as being a functional gastrointestinal disorder over the last 7 or 8 years, partly because the term functional sort of questions the legitimacy of IBS as a diagnosis, and therefore that sort of leads to stigma for people who suffer from IBS. And there's been increasing evidence over the last 20 years or so that IBS can arise as a sort of as a result of dysfunction in the gut-brain axis. So the brain controls the function of the gut, and it controls sensation and motility and things like that. So if there's a problem with the nerve supply to the gut, then that can lead to bowel dysfunction arising from this brain-gut axis dysfunction. And so that has kind of led to the reframing of IBS as one of 33 adult disorders of gut-brain interaction. And I guess, because the gut has a limited repertoire of symptoms, there is always, overlap between the constellation of symptoms of IBS with other structural problems in the gut, like celiac disease or inflammatory bowel disease. And that leads to some diagnostic uncertainty, I guess, doesn't it? That, although we're making a clinical diagnosis mainly in people with IBS, you might miss these other conditions. And so that's something I've studied quite a lot. And I've been involved in guidelines about how to diagnose and manage IBS. And, for the most part, if people are endorsing symptoms compatible with IBS and they don't have any concerning symptoms, what we'd call alarm symptoms or red flags, and you rule out the simple things like celiac disease and inflammatory bowel disease, then generally a diagnosis of IBS is secure. And that's moved away from this kind of diagnosis of exclusion that is what used to be sort of standard practice.
And that's one of the things I think frustrates people historically is they'll say something akin to, well, my doctor said it's just IBS, as though it means, go away. That's not so much so a thing. Now, on the one hand, I kind of get that, meaning to your other point, there's no alarm symptoms, or if there have been, you've ruled out anything that's more, air quotes here, medically wrong, celiac, colorectal cancer, inflammatory bowel disease. So in a way, it's almost kind of a good thing that your doctor has said you have IBS because you've ruled out likely other more serious conditions. But it does leave kind of the stigmatized, is it all in my head? Or, well, now you've just taken my symptoms and organized them into a label, but what do I do with that? So I kind of get where that comes from. But there's also, I think, a really important body of research looking at IBS and showing, hey, yeah, those people who maybe feel poo-pooed by the diagnosis have got randomized control trials and meta-analyses of therapies that can help them. So it's not to say it's just a nothing burger of a diagnosis. There's definitely treatments here that can be helpful and efficacious for those unpleasant, albeit maybe not dangerous IBS symptoms.
Completely agree. And I think it's a question of how you frame that discussion. Um, Really, it's important to understand that it's just IBS, because the symptoms of IBS impact just as much on quality of life and social functioning as having inflammatory bowel disease. So, I think if you come at it from a perspective as a physician of saying, I don't know what's wrong with you, it must be IBS because it's not any of these other things, then I call that like the dustbin diagnosis. Because basically or maybe in America would be trash can diagnosis. You're kind of, it's just, you're sort of, well, if all else fails, this is what it is. And it's not a big deal. It's not anything serious. So I would come at it from the perspective, if I was seeing a patient, is that I'm telling the patient already at the first consultation, I think this is IBS, almost certainly. There's a 5% chance that we might be dealing with celiac disease or inflammatory bowel disease. I'm going to do some very limited investigations that will rule these things out, but my working diagnosis here is IBS, and this is the prognosis, and this is the etiology, what causes it, and this is the impact, and I completely understand, why your symptoms are so troublesome and why you're coming to see me at this time. And that's a completely different conversation, isn't it?
Absolutely. And to circle back on one of your points that I think our audience is probably fairly accustomed to hearing is that IBS can impact your quality of life because it can impact other things like anxiety, depression, insomnia. It clusters with other things. Can you maybe speak to that briefly in terms of the person who's saying, oh boy, I feel like when my gut isn't feeling healthy, other things aren't good either. I feel more depressed, more fatigued. Can you speak to that?
Of course, yes. So, I mean, obviously, the gut brain axis is bidirectional. So, problems in the gut can lead to problems with mood, but equally, problems with mood can lead to triggering of IBS symptoms. So, it becomes almost a vicious cycle. And obviously, sleep, sexual function, daily activities, particularly for people with IBS who experience diarrhea, they can get really profound urgency and having to rush to the toilet and fear of incontinence. So that means that they can, some people become almost housebound because they're worried about their symptoms. And also that often leads to a vicious cycle as well, because when they do try and go out, because there's all this fear about where the toilet may be, that sort of is acting downwards on their gut and making, their symptoms worse. So yeah, absolutely. IBS can affect all the facets of life, and it can affect mood. And obviously, there are lots of other symptoms that people with IBS experience, like backache, joint pains, headaches, etc., brain fog, all these kinds of things.
If this has been helpful, please subscribe, comment, and if you wouldn't mind, share this with one person you think it might help. And I guess building on the psychological and brain component of this is one of the reasons why I and we at the clinic have tried to be really cognizant of not having a fear mongering perspective over anything that touches this conversation regarding food. You know, let's say fearing people about gluten that may not be justified or dairy, albeit we want to identify those triggers and help people see if those are foods they need to avoid. We don't paint with this broad brush. Well, you've got IBS, you can't have dairy or gluten ever. Or the same thing with maybe a SIBO diagnosis, because it can prey upon people's psychology, which is a really important, and I think to your points, probably a growing importance in terms of the perspective we take to treatment of IBS successfully, which is really making sure that we don't skew someone's emotions, more than they already are. When, like you're saying, if someone's worried about going out, where's the closest toilet to where I might be going? And maybe I won't go there if the toilet's not close enough. There's already enough going on psychologically to where I think we want to be really cautious as a healthcare community not to exacerbate that fear.
Yeah, sure. I mean, overly restrictive diets can cause as many problems as they solve for people with IBS. And, it's well known that it's often just the act of eating itself that will trigger symptoms, because symptoms are to some degree meal related, and defecation, opening one's bowels for most people is meal related. Most people have their bowels open in the morning after they've had their first meal of the day. So often, the kind of dietary triggers that people, that suspect as being the thing that's triggering their symptoms, they're often not reproducible on double blind testing, as I'm sure you know.
Yeah, and it's important, I think, in some cases to tell people or sort of to kind of guide them to that perspective, because I'm so glad you made that point. It could be any food. And we have this conversation oftentimes with people, which is if you haven't been able to correlate foods as a trigger to your symptoms, then it may just be food in general. And so let's start to broaden your diet. And for a surprising number of people, they bring back in dairy or gluten or grains or whatever it may be, and they say, that doesn't seem to be a consistent trigger. And now I've been able to broaden my diet. I'm going back out to dinner, whatever it is. And sure, in parallel with that, we want to work the problem and try to lead to sort of global IBS resolution, but doing that in the context of a diet that's not overly restrictive.
Yeah, I agree completely.
SIBO is something that comes up as, okay, you've been given this sort of dustbin diagnosis, as you said, and people then go searching for, well, what could be driving this? SIBO is one that comes up, and I'm pretty open on and interested in SIBO. We have actually at current in peer review a paper looking at different treatments for SIBO in a comparative fashion. So, I'm on the team, so to speak. But also, when you look at some of the data, there was a recent meta-analysis that found, this is looking at breath testing, but IBS patients had a 36% positivity rate for SIBO. Healthy controls had a 28% positivity rate for SIBO, only an 8% difference between the groups. And this is from a meta-analysis. This isn't me cherry picking one best case scenario study. And I think that's important for our audience, because one of the things I'm noticing is the acknowledgement of SIBO is outsized to the prevalence of SIBO, or at least from my vantage point. So not saying it's not a part of the conversation, but I think it's really becoming oversized. That's my perspective. Thoughts on SIBO?
Well, absolutely. I mean, a very thorny issue to deal with. The main issue being, the gold standard to diagnose SIBO is to do something that's quite invasive, and an enteroscopy, and aspirate, jejunal or small bowel fluid for culture. Whereas, most studies that look at the prevalence of SIBO in people with IBS are doing something called breath testing, which is actually giving a person a carbohydrate, and measuring when it may or may not be being digested by the gut's bacteria. And there's evidence from some of the more elegantly designed breath test studies, where particularly a study from a Canadian group where they did a breath test at the same time as giving the patients a radio labeled meal, that actually the breath test is a marker of transit for some people. So people with rapid transit who look like they've got bacterial overgrowth, what happened was actually the sugar had already reached the colon and was being fermented by the colonic bacteria because it was there at the same time as the meal. So the rise in the breath hydrogen was actually corresponding to the sugar reaching the colon and being fermented there, and therefore this is not a marker of SIBO in some patients. And as you say, prevalence of 35%. I mean, for most people with SIBO, there's really, you would imagine there has to be a structural explanation for that. So, they've had a partial gastrectomy, or they've had previous intestinal surgery, or they've got diverticulosis of the small bowel, or they've got a multi-system disorder like scleroderma. But, most people with IBS won't have those sorts of risk factors. So it's unlikely that the prevalence of SIBO is 35% or whatever in people who meet criteria for IBS.
Right. And then you have the Mark Pimentel hypothesis of post-infectious IBS stimulating an autoimmune process in the gut that thwarts proper motility. But even with that being said, we'd likely see, in my opinion here, a higher prevalence of SIBO in IBS populations discriminating from healthy controls if this post-infectious IBS hypothesis was as common as it's portrayed to be.
Yes, and of course, I mean, only around about 1 in 10 people with IBS will be able to identify a precipitating acute enteric infection. So that doesn't account for the other 90% of people. And, I don't know if you're probably aware of the very nice paper in Nature from a couple of years ago that showed that if you infect a mouse with a bacterium at the same time as feeding it a particular dietary antigen, and then you reintroduce the dietary antigen after the infection is resolved, what actually happens is that the infection breaks oral tolerance to the dietary antigen, and then the dietary antigen can start to interact with the immune system and create an immune response, the hallmarks of which were diarrhea and abdominal pain, which are symptoms compatible with IBS. So that's another way. I'm not sure that a gastroenteritis is always sending someone down the SIBO route. It may be that it's breaking tolerance to a normal dietary antigen.
Yeah, and let's put on the board the immune system component, because I definitely want to come back to that in more detail in a moment. One thing I just wanted to make as a side remark is I have this growing concern that people are conflating I've responded to a SIBO treatment with that means that I have SIBO. And if you look at the research literature, there's actually more people who respond to SIBO treatments, whatever they may be, than actually have SIBO. And if we don't acknowledge that, then this canard can kind of propagate where people keep trying SIBO treatments, whether it be rifaximin, an elemental diet, maybe a probiotic, maybe a low FODMAP diet, and they say, well, I responded, therefore I have SIBO.
Yeah, sure. And I mean, it's further compounded by the fact that the pivotal trials of rifaximin in IBS were not done in people who had a positive breath test, of course. They were done in all comers. And actually, if you look at the therapeutic gain of rifaximin over placebo in those trials, it is a remarkably similar therapeutic gain to that you see with eradication therapy for Helicobacter pylori, which consists of two antibiotics and a proton pump inhibitor in people with functional dyspepsia. So, you can't rule out that antibiotics have a beneficial effect in people with these disorders of gut-brain interaction like IBS and functional dyspepsia, but whether that's arising from treatment of SIBO, I think is debatable.
Exactly. Yep. I think that's a great point. So coming to gut brain, and I'd like to sort of trace gut brain to the immune system. There was this really interesting paper, 2017, in the journal Gastroenterology. They gave people with IBS who also had depression and anxiety Bifidobacterium longum, 10 billion CFU per day, and they did functional MRI scans and found a reduction in the activation of the amygdala that corresponded with improvements in depression and anxiety, which I find really fascinating and sort of or reinforces in part your hypothesis or part of your hypotheses, which is this gut brain access and not just a functional gastrointestinal disorder. That was one of the first studies that I came across that really showed a tie between the gut and the brain and therapies that may be able to modulate both. Um, how do you think about the gut brain access? I mean, there's a lot there obviously to unpack, but I'll just throw up that one study as sort of a volley into the conversation.
Yeah, so I mean, I think that study's interesting in as well in that it was a randomized controlled trial, and I think the people who were responders to the probiotic were more likely to have an improvement in their mood scores as well, if I'm remembering correctly. So obviously that's
Yeah, the IBS symptoms and the mood scores tracked. I believe so
yeah.
too. Yeah.
So I think that's an interesting window into how the microbiota can interact with the brain gut axis. So some people call it the brain bug gut axis. Um, so yeah, I mean, obviously, that's an example of the probiotic being able to have perhaps central effects through the gut brain axis. I mean, obviously, other treatment in IBS usually is directed more towards the peripheral um, consequences of gut brain axis dysfunction. So, you know, drugs like antispasmodics or peppermint oil working on presumably on visceral hypersensitivity or the pain that arises from visceral hypersensitivity, and perhaps also working on motility, and what we'd call gut brain neuromodulators, which are drugs that are conventionally considered as antidepressants but used at a much lower dose than
Mm.
for the treatment of depression, acting on pain signaling. And I think that's one of the things that came out of our trial that was published in the Lancet recently, which was a definitive trial of amitriptyline for irritable bowel syndrome in primary care, was that we measured both peripheral symptoms, so global IBS symptoms and abdominal pain, but we also measured mood during the trial and during the 6 months of treatment with the amitriptyline versus the placebo. There was an improvement in the peripheral symptoms, so the global IBS symptoms and the abdominal pain with the amitriptyline over the placebo, but there was no difference in mood scores during that trial at all. So that suggests that although amitriptyline has central effects, or certainly has antidepressant effects, it wasn't acting as an antidepressant. It may be having central effects in the trial, but the central effects weren't an improvement in
Right.
mood. So I think that's really interesting.
Yeah, I think it's really interesting also, and I really appreciate how you have changed the labels that we may use from, these are antidepressants that are being used for people who are depressed or it's all in your head, toward these are gut brain neuromodulators, if you will. And I think that that reframing is really hopefully for people empowering. And the amitriptyline data that you published, I think, is also super interesting in the sense that as we modulate serotonin and norepinephrine, we're seeing this favorable change on these symptoms. And it also has me wondering, since serotonin modulates the immune system, we know it partially functions as a chemoattractant. It'll pull immune cells to sites of inflammation. It can modulate macrophages and monocytes. How do you or how much do you think that the amitriptyline is, in part of its mechanism of actions, influencing the immune system? And this kind of ties back to your comment on oral tolerance. So if there's this whole, interconnected web of causality and loss of oral tolerance to food, which is mediated by the immune system, is part of this, do you think part of what these previously called antidepressants, now called sort of gut brain modulators, are doing is affecting the immune system in a favorable way?
Really, really insightful comment and question. I think, firstly, I'd just point out that it's Doug Drossman who is the sort of godfather of disorders of gut-brain interaction. Who first was one of the first people to introduce this concept of low-dose antidepressants being gut-brain neuromodulators. So that's not something a term that I've come up with, although I've been involved in work with him to summarise the evidence for the efficacy of these drugs across all disorders of gut-brain interaction. Um, but yes, because tricyclic antidepressants are 60 or 70 years old, they're a drug that, I guess in inverted commas is quite dirty because they have multiple effects on different receptors. So they have serotonergic effects, they have effects on norepinephrine, they have antimuscarinic effects, which often lead to the side effects that patients experience, like the dry mouth and the drowsiness. But they also act on histamine, so they have antihistamine effects. And interestingly, going back to the break in oral tolerance in the mouse model, but also this has been observed in humans. In people with IBS, you do see in studies report that people with IBS have mast cell activation, not mast cell activation syndrome, because that's a completely different thing, but that there is evidence of immune activation in the mucosa of people with IBS, where you see mast cell degranulation, perhaps in response to a dietary antigen, with release of histamine, and these mast cells are quite close to peripheral nerve fibers in the gut wall and are probably triggering sensation, causing nociceptive effects. So actually, the tricyclic, it may be improving pain signaling through norepinephrine, but equally, because of these histaminergic effects, it might be that it's acting on mast cells and stabilizing them or preventing the release of histamine. And so, we don't know because we haven't studied the mechanism certainly we didn't study mechanisms in my trial of the drug at the Atlantis trial.
Man, that's fascinating because we've had mast cell activation researchers on the podcast. And at least I think we can speculate that in IBS, there might be increased mast cell sensitivity and or a higher density of mast cells. I know some people have made those posits. And some people derive benefit from low histamine diets or other agents that lower histamine. So this all makes complete sense. I love the connection. It also has me wondering, and this might be a big ask of the research body, but do you have any sense, is there anything published showing that people will improve oral tolerance over time, or at least seemingly so, meaning that they might be able to use amitriptyline for 6 months, a year, what have you, and then come off the drug and maintain improved food tolerance or at least reduced symptoms?
Yeah, I'm not aware of any studies like that. I mean, in Atlantis, our trial of amitriptyline, we used the drug for 6 months, and we offered participants an extra 6 months at the end if they wish to continue it. Dr. Drossman's theory on the length of time that you would use those sorts of drugs for is that it's a bit like the literature for depression, that the shorter the period of time before you discontinue it, the more likely your symptoms are to relapse quite badly. So I think he feels that at least 6 to 12 months is reasonable, and that's what I would tell my patients. Just going back to the histamine issue, you may have seen recently that there was a Belgian trial from Guy Boxtan's group, which used a histamine 1 receptor antagonist called ibastine in IBS. Now that's a drug that's licensed for use for, I think, chronic urticaria and allergic rhinitis. And that again was beneficial, superior to placebo in that trial.
Yep, that makes complete sense. And I know a lot of our audience is interested in histamine, and the 6 to 12 months makes sense. And I'll say this in terms of knowing that so many of our patients or people in our audience, they might be open to drug therapeutics, but I think they're all trying to be minimalistic with the amount of dietary restrictions, with the amount of supplements they take, with the amount of drugs they use. So knowing that this wouldn't be you're on this for the rest of your life to quell your symptoms, but rather there might be the likelihood or the potential to regain food tolerance after that 6 to 12-month period, and then discontinuing the drug with maintained benefit speculatively, right? It hasn't been demonstrated, but I think it makes sense. Like you're saying, borrowing from the arc of depression literature, then that's more of a corrective than a palliative measure. And I think people will be more excited about that trial, doing that trial on themselves, I mean.
Sure, exactly. And because obviously, certainly for the doses that we're using of tricyclic antidepressant type drugs, these are low dose. So It's not, they're not, you're not going to have to wean them off over months. If you're taking 10 milligrams of amitriptyline for 6 months and
Good
you want
point.
to stop it, you can just stop it.
Yep, that's a really great point also. Hey everyone. Okay, so we took a moment to look into a few of these interesting mechanisms regarding amitriptyline, starting with animal and in vitro data. There was one interesting study finding a reduction in gastrointestinal inflammation in a mouse model of inflammatory bowel disease. The dosages used of amitriptyline were pretty high in this study. A different study found antimicrobial activity against pathogenic bacteria. No studies in animal or in vitro looking at leaky gut. And there weren't any studies that have checked for these effects in humans, the leaky gut antimicrobial activity at a lower dose like is used in IBS. There are human data showing modulation of gut pain and sensitivity and motility, as I think Dr. Ford's doing a great job of pointing out. But in any of these human trials, we were looking to see how maybe there's a mention of a reduction in cytokines and inflammation, and we weren't really able to find anything that has looked into this in the research, at least yet. And then also looking at this potential for corrective effects. Let me first say, I don't think there's enough research to really adequately answer this question, but from the minimal amount of research that is present, there are not any studies looking at what happens after discontinuation of amitriptyline for the treatment of IBS. We did look into depression with the thinking maybe if people are on amitriptyline for depression 6 to 12 months, and then they can discontinue and maintain mood improvements, that would sort of reinforce there could be this corrective effect in the gut-brain axis, if you will. We weren't able to locate any studies that support this. The trend was more so that there was regressions of depression after discontinuation. However, these trials did use much higher dosages than recommended for IBS. So again, I think it's really too early to say. Just wanted to add what myself and the research team was able to dig up. Let me bring us to probiotics. We had a nice back and forth via email on probiotics. Given the fact that you've authored a meta-analysis, I was keen to pick your brain. I'll give my perspective, and then I'd love to get your perspective. We can kind of compare rationales. When I look at probiotics, I see lots of research being published showing benefits in IBS, some benefits with constipation. And we can even go to things like anxiety and depression showing benefits, children and reduction of atopic diseases. So there's a pretty broad breadth of data. One of the challenges I see is that they're smaller trials. So oftentimes they're 30, 50, 70 people. They're not hundreds or thousands. There's a few larger ones, but the general skew in the data is they're smaller trials. And there's inconsistency in terms of the formulas used and the dosages therein. So it makes it harder to say, well, this is the formula that we should recommend for a duration and at a given dose. All that being said, I think there's clearly, if we're adhering to kind of evidence-based dictates, if we have RCTs and we have meta-analyses, that at least opens the door to say, okay, it's reasonable to do a trial. I'll say that and also say in tandem, I see other dishonesty in the probiotic field. As one quick example, Akkermansia mucinophilia is a newer probiotic, and you're seeing people from that company make all these rounds on the podcasts and YouTube-osphere, making claims that the data don't support. This is a key probiotic for your gut health, yet they don't have any outcome data. Nothing in IBS, nothing in pain, constipation. They have one small study showing improvements in leaky gut, but to represent Akkermansia as this new, novel, and very beneficial for gut health probiotic is dishonest because the data don't support that. So if we can be good about not falling into fanfare of new therapies and look at what's being published with at least RCTs, I think we can very justifiably say, do a trial on probiotics, have a reasonable expectation, look for it to benefit you within the first 1 to 3 months. And if it does, great. And if not, discontinue. That's my perspective. What's yours?
I agree with most of what you said. I think it's difficult sometimes with the probiotic literature in IBS, and that's why we update it. I think this is the third or fourth iteration of that meta-analysis. So when we started, my mentor and I, Paul Moyedi, we did the first meta-analysis in 2009, I think, and there were around about 10 or 11 trials of probiotics in IBS. There's 82 now. So we updated the meta-analysis last year with the 82 trials, and so that's a huge number of trials, more than of any other treatment in IBS that I'm aware of, and over 10,000 patients in these trials. So, this is a large body of evidence. And what I hoped this time was, because there were so many trials now and so many numbers, such huge numbers of patients involved, that we'd be able to start to sift through and try and pinpoint which particular brands or strains or species of probiotics were the ones where the evidence suggested there was a benefit. And I also thought, well, with 82 trials, what we'll be able to look at is their effect not just on global IBS symptoms, so the overall symptoms of IBS, but also specifically on abdominal pain and abdominal bloating or distension. So we really kind of went to town on this update in terms of extracting data for all these different symptom endpoints according to the combination of probiotics used, according to the individual combination of probiotics used, according to the strain, according to the individual strain and species, to really try and drill down so that we could say, hey, this particular combination or this particular strain and species is beneficial for abdominal pain, but this one is beneficial for bloating. And unfortunately, that even with 82 trials, it becomes very difficult because you're dealing with a sort of ever diminishing number of trials in each category of the same, preparation. So, I mean, I think, to give you kind of the headlines and deadlines, there is obviously evidence that, some of these probiotics work, but it's hard to get to the, to the nub of which ones it is. Overall, particularly for global symptoms, there's a strain and species, Lactobacillus plantarum 299V, which seemed to be beneficial for global symptoms, and that was in, I think, around about 5 trials. And there was evidence for Saccharomyces cerevisiae, I think I've pronounced that correctly, for abdominal pain. And there was also evidence for Lactobacillus strains as a whole and Bifidobacterium strains as a whole for pain. For bloating, it was really, by this stage, when you're down to that symptom, there were fewer trials reporting that. And I think there was only trials of Bacillus coagulans that demonstrated a benefit. I think the main thing to bear in mind, though, when you're dealing with the probiotic literature is that if a pharmaceutical company comes along with a new drug for IBS, they've got to get it licensed, and they have to go through the hoops that the FDA specify in North America, or the European Medicine Agency specify in Europe. And they have to have a minimum trial duration of 12 weeks, and they have to use endpoints that are pretty stringent for the drug to get approval. So, for a drug in IBS, you have to have been able to show a beneficial effect on a composite endpoint that consists of both a 30% or more improvement in abdominal pain and an improvement in stool frequency if you're dealing with constipation, or stool consistency if you're dealing with diarrhea. Whereas in most probiotic trials, the endpoints are, not as rigorous as this. They're more kind of adequate relief, or, global assessment of symptoms, or a 50-point increase on a
Yeah,
a
and let
50-point
me ask one
decrease.
quick question right there. Sure, sure. Because one of the things I'm wondering is the IBS symptom severity score.
Yeah.
Do you think that's sufficient, or is it too subjective in your view?
I mean, I think it's been
Because you see
well,
that
it's,
come up, just for our audience, you see that come up a lot in terms of
yeah.
of an inventory that they kind of do a pre-post, and we're thinking about doing this on a future trial. So, if there's a way we can sharpen our analysis, I'd love that.
So I think the IBS SSS, the IBS severity scoring system, has been used, in hundreds of studies. So and it's been validated. The original validation study was done probably 30 years ago now. So it's been around for a long time. It's been validated. It's been used. We know from the original validation study that a 50-point change within the same person in the score is felt to be clinically relevant. But I think that's quite a low bar. So often, if in a placebo-controlled trial, if you use that 50-point decrease in the IBS SSS, then the placebo response rate is quite high, and therefore you may make it less likely that you'll see a benefit of your, experimental intervention, your new drug or your probiotic or whatever. Some people say you should go for a 75-point or even a 100-point decrease to try and increase the stringency of the endpoint. I mean, it captures 5 different domains. So, it captures pain, frequency, pain severity, it captures bloating and distension, it captures bowel habit, and it captures the degree of impact that the person's IBS symptoms are having on their life in general. So it's an intuitive measure of symptoms, but it's not as stringent as using an FDA endpoint.
Gotcha. And could it be an issue that some people may experience more of one of the subdomains than another? It makes me wonder if, looking at these key symptoms individually and then separate to that doing the composite score might allow you in a sub-analysis to pick up signal where, and I think you see this in some of the probiotic, abstracts at least, where they'll comment that there may not have been global IBS SSS reduction, but there was an improvement in bloating and in frequency. And is this hard to disentangle? Because I know not everyone is going to have, let's say there's 4 main hallmarks of IBS. Not everyone's going to have an equal presentation of all 4 across the board. So how do you think about disentangling that?
That's a really good point. And this is exactly what we were trying to address in the meta-analysis when we split everything into global symptoms, abdominal pain and bloating. I mean, abdominal pain is a cardinal symptom. So you have to have abdominal pain to meet criteria for IBS. So measuring abdominal pain as an endpoint is intuitive because it's one of the cardinal symptoms. But yes, you're right. Bloating, not everyone will have bloating. Bloating is not a cardinal feature of IBS or bloating or distension. It's felt to be a supportive symptom, but it's more common in women than men. Right. It probably only affects about 60% of people with IBS. It probably affects those with constipation predominant IBS more than those with IBS with diarrhea. So yes, you could have theoretically someone who fills out the IBS SSS who scores 0 in the bloating and distension domain of the questionnaire, and therefore they can't improve on that parameter because they didn't have that symptom to begin with. Precisely.
Well, that's a great insight from your paper, and now I have a better understanding as to why this is often reported as both the composite score and then the components of it, which makes complete sense. Okay, just a few things I wanted to add here. I really appreciate this clarification that Dr. Ford is making, and a few pieces of context I wanted to add, sort of complementing what he and we were discussing, that the IBS symptom severity score is a validated measure of IBS. It assesses abdominal pain, bloating and distension, bowel habits, and IBS-related quality of life. And the clinically meaningful endpoint is when the IBS symptom severity score changes by 50 points. And Ford suggests something that might even be more appropriate to really translate to someone saying, yeah, I feel better. And that's 75 points. Now, there was actually quite fortuitously a meta-analysis published later in the year 2023. This one looked at 81 randomized control trials in over 9,000 patients for IBS. And if you extract some of the points from their data table or tables, this is published in Nutrients, by the way, what you're seeing here, I find to be really telling and also kind of supporting the data that justifies at least a trial on probiotics. And you're seeing here Bifidobacterium animalis, 49 points, so not significant, but then a number that were 64 points, 76 points, 77 points, even 81 points. And again, the way I interpret this is when looking at the individual species, this is why I feel comfortable about recommending just a good quality blend of lactobacillus and bifidobacterium, because you see so many different strains or technically species here. L. plantarum, L. casei, L. acidophilus, bifidobacterium longum, strep thermophilus. A different study did find favorability for bifidobacterium animalis in the 76 point, along with Lactobacillus plantarum, Lactobacillus casei, Lactobacillus rhamnosus, Bifidobacterium longum. So, this is part of the reason why I've been an advocate for the position of I don't think we have to be overly fastidious about the constitution or the components of the formula, because many of these different species are showing above the 50 point cutoff. And if we're going to use what I think is a great point by, again, by Dr. Ford, to cut 75 or higher to really make sure people will notice a clinical difference, then, again, we have 1, 2, 3, 4, 5, 6 different species within the categorization of lactobacillus and bifidobacterium blend probiotics. So anyway, just wanted to follow on with those, and okay, we'll go back to the discussion now. Coming over to some other therapies, there's a transition that I took from, there was a lecture, I'm not even sure what body this was from, but I was watching one of your lectures earlier in the week, and you made a great point about peppermint oil when it was essentially colonic release had far less efficacy as compared to peppermint oil that was small intestinal release. And this got me thinking about some manufacturers for probiotics will claim it's got to be acid protected, enteric, or sort of large intestine opening. And I've always made the argument that the small intestine seems to be in large part where a lot of IBS is emanating from, given it's much longer. It's where the predominance of leaky gut, immune receptors, caloric and nutrient absorption occurs. It would seem that we want to have a modulating effect there, and definitely immune system, given all these immune receptors and inflammation. So that was kind of validating in a tangential way that, yes, let's get the therapy into the small intestine and maybe not be so concerned about the colon. Not, no disrespect toward the colon, but I think the small intestine is where we want to be focusing some of this force.
So I think it's interesting, isn't it? Because I think people do view IBS as more of a colonic disease for some reason. I think for some reason when people think of irritable bowel syndrome, they think of, oh, it must be the large bowel. But actually, we forget that there's much more of the small intestine, and it has many more functions, and is much more complicated than the colon, which is primarily dealing with salt and water homeostasis. So yes, I mean, I think that peppermint oil trial from Dan Casevely is an interesting study, and I think the makers of linaclotide have went down a similar route with trying to manufacture various different modified release versions of linaclotide to see if that could have an effect on pain, but without leading to diarrhea, because obviously that's how it's treating IBS with constipation, is that it's drawing water into the colon because it's a secretagogue, and therefore improving stool frequency and consistency. But obviously, if it had an effect on pain alone, if it was acting in a particular region of the bowel, then that would mean that you could give, and it wasn't having an effect on stool consistency or frequency, then that would mean that you could give it to people with IBS-D or IBS with a mixed bowel habit without them experiencing an exacerbation of their diarrhea. But unfortunately, that trial was negative. But I think that kind of is possibly pointing a way forward where where future studies need to go. I agree.
And with peppermint oil, I believe it has some immunomodulatory impact. It's an antispasmodic, and I think I've seen somewhere that it might be a mast cell stabilizer, although I'm not sure how credible that was. For people who maybe haven't heard much about peppermint oil, can you give them sort of the synopsis?
Yes, so I think it can act as a smooth muscle relaxant, but it also works on, I'll try and say this right, TRPV receptor. So it works on, which is a pain signal. So it can modulate pain sensation. So the potential is that it's working perhaps in at least 2 different ways in IBS. And again, I mean, it won't surprise you to learn that we've done meta-analyses of peppermint oil over the years, which have been updated again as more trials have have come through. And when we first started in 2007 or 8, I think we published a meta-analysis in the BMJ looking at antispasmodics and soluble fiber and insoluble fiber and peppermint oil. And around that time, I think there were 4 or 5 trials of peppermint oil, which were showing a clear benefit of peppermint oil in IBS. But again, similar to the probiotic literature, the endpoints used in those trials, which are more historical, are less stringent than current recommendations for
Right.
endpoints in trials in IBS. And what we've seen as newer trials have come through, like the Ketseveli trial of the 2 formulations of peppermint oil, and another trial from Tony Lembo's group, is as we've incorporated those trials into the meta-analysis, the efficacy of peppermint oil has become more modest because the more recent trials that use the more stringent endpoints, um, don't really show that peppermint oil is hugely beneficial in IBS. But when you pool them together with the older trials that are showing quite a marked effect, there's still an overall benefit. But the efficacy is much more modest than that which we previously estimated, I think. But I still think, again, for your listeners who are people who've probably, may have tried drugs and had side effects, or feel like they've tried all the drugs that are out there and want to use something that's more natural, then, the side effects from peppermint oil are relatively minor. Reflux sometimes, which, reflux can be more common in people with IBS in any case. So giving them peppermint oil may make that worse, but generally peppermint oil is safe, and it may be worth trying. It's more efficacious than placebo in our meta-analysis for sure.
Right, right. And one of the things I think about when you say this is a positive selection bias, or just a selection bias where new therapeutics tend to have the favorable studies published first, and then over time you see a little bit more of a regression to the mean, if you will. It sounds like in this case it's more so due to the endpoints being more stringent, but maybe just as an aside for people, because I've often recommended caution when there's just 1 or 2 randomized control trials. Sure, let's look at that. That's an amazing start. But sometimes you'll see, again, this arc where the most favorable studies are published first, and then over time, the conclusions become a little bit more tepid. They may still be beneficial, but have you seen, I'm assuming you've seen that. I'm just wondering if you have any thoughts for people so that they don't think that I'm just trying to throw a wet towel on the party all the time and I'm trying to exercise due circumspection.
I, I think that's exactly right. And I guess I would frame it this way, is that normally the first few trials of a treatment, particularly if you're trying to repurpose an old treatment or a treatment that, you know, is unlicensed, they're usually quite small trials. They're usually done by a single group of investigators. And what we know is that small trials tend to do one of 2 things, which is they either show a positive effect of the drug or a negative effect. And the estimate is usually a big estimate. So that if they show a positive effect, it's usually going to be a big effect because it's an imprecise estimate because they're small studies. And then what happens is that if the study's negative, it doesn't get published. So when someone comes along, so a really good example as a case in point would be our meta-analysis of tricyclic antidepressants, which is a meta-analysis that, again, we did in about 2008, which was published in Gut. And around that time, I think there were 7 or 8 trials of tricyclic antidepressants. And what was interesting was that all the trials showed a benefit. When we look at the forest plot, all the trials show a benefit of tricyclic antidepressants. But most of the trials, the confidence interval, in other words, the kind of how confident we are around the result of the trial, crossed the line of no effect for nearly all of those trials. Now, when you pool them together, the power of the meta-analysis gives you a much more precise effect because you've got 8, 9 trials with 500 patients in. So overall, at that stage, tricyclic antidepressants were more effective than placebo for IBS, and the number needed to treat was around about 4. And that, to some extent, that's one of the reasons why we do meta-analysis, is so that we don't discount potentially effective treatments on the basis of small studies that are underpowered. But remember that the meta-analysis derives its bottom line result from all those studies that are probably showing extreme results, extremely positive results. And so in our hands, when we did the Atlantis trial using amitriptyline, we randomized 463 patients to either amitriptyline or placebo. Now that's almost as many people as were in that meta-analysis. And I mean, it's important to point out that we would never have got the Atlantis trial funded if we hadn't have done that meta-analysis in the first place to show this signal that tricyclic antidepressants might be beneficial in IBS. But what's interesting is in the Atlantis trial, the therapeutic gain of the amitriptyline over the placebo, in other words, how much more effective it was than the placebo, is smaller than in the meta-analysis. So the number needed to treat from Atlantis will be round about 8 compared with 4 in the meta-analysis, because it's probably giving the true effect of a tricyclic antidepressant in IBS. It's modestly effective. A number needed to treat of 4 is, is like a wonder drug, and that doesn't correspond to our clinical experience of using tricyclics, because the people will have side effects, they'll stop them, etc., etc. So that's why that happens. I think, having reflecting on years of being a meta-analyst.
No, it's very well said, and I think for the patients and the healthcare consumers out there, just bear this in mind in the sense that a new randomized control trial is likely going to give you a better or best case scenario, which may not actually be representative of the experience you as a person would have, which is why I think a clinician should be open-minded, but sometimes they pull the person back in terms of, well, it's a randomized control trial, that's great, but let's see what the larger body of evidence shows. Or at least if you do run an experiment on yourself, be cognizant not to placebo yourself in terms of, oh my goodness, I'm so excited about this thing. And now even if we gave you a sugar pill, you'd probably report a benefit knowing the power of placebo. And I also guess we could make maybe an argument for placebo if it's not something that's expensive or invasive. Then, okay, would a little bit of placebo be the worst thing in the world? No, because the mind's a powerful thing, but I think we're all obviously trying to protect against placebo as much as possible.
Yeah, I mean, I think that's an interesting concept. And again, it comes back to how you frame that to patients using placebo. And so I think there's a really interesting paper on this from Tony Lembo's group, sort of about using placebo without deception, I think is called, or something along those lines, where they randomize people with IBS to either no treatment or a placebo, and they were told this is an inactive sugar pill, but it has mind-body healing processes underlying it. And really interesting that the placebo was more effective than no treatment. So that just shows you that placebo does have a benefit in IBS. It is an amazing result, but equally, placebo will have a benefit in inflammatory bowel disease trials. The stringency of endpoints in inflammatory bowel disease trials is high, and yet 9% or 10% of people will experience mucosal healing with a placebo infusion. So placebo has effects that we don't really understand in all conditions, really.
Right. I guess it's kind of the brain gut connection also at play. That's a great study. I'm going to look that up. That's pretty interesting. One of the areas where I think we have no SIBO, a negative expectation, is with food. And probably in part for good reason. People are associating to some extent eating with triggering their symptoms. And I'm assuming Chris Black, who's also at University of Leeds, and he's done some really interesting work on the low FODMAP diet and that efficacy, or the efficacy therein. What are your thoughts on the low FODMAP diet? We've talked about it on the podcast ad nauseum in the past, but would love to hear your thoughts.
So yes, Chris Black is a declaration of interest. He's my mentee. He's a fabulous researcher, and I'm lucky that he works with me now in Leeds as a full-time colleague. So yes, we did a systematic review and network meta-analysis of looking at the efficacy of the low FODMAP diet in IBS with Heidi Staudacker, who's an academic dietitian in Australia, and we compared it with all the other dietary interventions that have been studied in IBS. So we looked at what's called NICE, British Dietetic Association, or NICE recommendations for first-line recommendations for diet in IBS. and also sham dietary interventions and habitual diet. So, in other words, in a habitual diet versus low FODMAP trial, you'd be randomized to either continue your own diet or the low FODMAP diet. And what came out of the meta-analysis was that we did a network meta-analysis here. So you can actually, in a network meta-analysis, you can actually rank the different interventions in order of the probability that they're the most effective. So low FODMAP diet came out on top, followed by the standard first line dietary advice that we give people in the UK, the BDA NICE dietary advice. And I think habitual diet and a high FODMAP diet came out last. So I think it's, one of the things that came out of that network meta-analysis was that low FODMAP diet wasn't actually superior to the BDA and NICE dietary advice, that the standard first line dietary advice. So that's one thing, is that it wasn't superior to anything else other than the habitual diet and the sham diet. And the other thing to say really is that most trials of a low FODMAP diet in IBS are only studying the exclusion phase. So the low FODMAP diet has three phases. So there's the first part, which is FODMAP exclusion. So that's when you take FODMAPs out of your diet completely, usually for a 4 to 6 week period, I think, although I may be wrong because I'm not a dietitian, but I think it's 4 to 6 weeks. And then there's a period of FODMAP reintroduction to tolerance. So in other words, you test whether or not by reintroducing a particular FODMAP containing food, your symptoms get worse. And then there's a personalization phase where you basically adapt your diet to reintroduce the foods that contain FODMAPs that didn't trigger symptoms and exclude the ones that did. So most trials only study that first 6 weeks, the kind of exclusion phase. There's only, I think, one of the trials that we looked at where it also reported efficacy out to the FODMAP reintroduction and personalization phase. Now, admittedly, that trial did still show a benefit of a low FODMAP diet, but yeah, the evidence is mainly based on the short-term period at the beginning of the diet. So my take on the low FODMAP diet clinically is it's useful. It's a useful treatment. It avoids having to use drugs, but there are things that you need to happen in order to be able to use it, and one of them is that you shouldn't do it on your own. So unfortunately, people do get told, "Oh, go and try the low FODMAP diet." So it's something that needs to be done with the support of a trained dietitian, what's called a FODMAP accredited dietitian, and it shouldn't be followed for the rest of your life. So it's not a permanent treatment. So you're not supposed to just exclude FODMAPs and just stay on a completely FODMAP-free diet forever. That may have deleterious consequences. We don't understand what the implications of that are, but it does seem to alter the microbiome in terms of changing the balance between various different bacteria like bifidobacterium in the gut. So that might not be healthy. So those are my two things that I remind patients about, that they shouldn't be doing it on their own, and it's not a lifelong treatment. They should reintroduce FODMAPs to some extent. And the other thing I was going to say about the low FODMAP diet is that there are particular patients who it might not be suitable for. So I think we've alluded to this earlier on, is that, people who are already have a very restrictive diet, or people who've got a low body mass index or things like that, or people with a history of disordered eating, are probably not suitable for a restrictive diet, and they might be better placed, using a drug or a probiotic or something like that.
Yeah, I mean, all great points. And we reviewed recently on the show a meta-analysis that looked at longer term use of the low FODMAP diet. I think this is hot off the press from only maybe a month or two ago. And the few points they made sort of echo your thoughts, which are, it's a phased diet, meaning the elimination is only for the first roughly 4 to 6 weeks. And then you reintroduce the tolerance. And if you're going to be on a longer term low FODMAP diet, it's one that's constantly trying to expand and bring in new foods. And one of the papers in that meta-analysis did find over 50% of the foods that were cut out could be reintroduced with tolerance, which I think is really optimistic and should be framed in the discussion going into the low FODMAP diet, which is, I had the expectation that more than half of the foods you cut out, you'll be able to reintroduce, kind of using placebo for good, as you mentioned earlier. but also being very careful not to do strict low FODMAP for 4 weeks and say, oh, this is my sort of forever diet. Because
Yeah.
for most people, there does seem to be something corrective. And even bringing in Tarek Mazawi, who wrote a paper, this is maybe 5 years ago, but they found that serotonin and PYY cells in the gut became more dense, more like healthy controls after using a low FODMAP diet. So there might be something sort of healing about low FODMAP and other data showing reductions in leaky guts and inflammation. So we should be thinking about it as you heal, your dietary tolerance improves, and you expand over time.
FODMAP containing foods also contain other potential triggers of symptoms in people with IBS. So, you know, a FODMAP containing food such as wheat, it contains fructans. So that's the FODMAP, but it also contains gluten, and it contains ATIs, these tryptase inhibitors. So there are, whether a low FODMAP diet is having its effects because of FODMAPs, or whether it's having its effects because it's taking out some other dietary components that might be inducing, for instance, going back to what we were saying earlier, an immune response in a susceptible individual is uncertain.
Well, I'm really glad you made that point, because one of the things I've been discussing on the show over the past few months is, okay, so we have this observation that people go gluten-free and they feel better. And we look at that anecdote, and people will then conclude, well, I'm not celiac because I had that ruled out by my GI, but I must be non-celiac, gluten sensitive, and so I'm just going to be on the gluten-free train forever. But if we come back to the meta-analysis I just mentioned, knowing that over half the foods that are cut out can be reintroduced, this, I think, changes the perspective on gluten avoidance, in that it might be the FODMAPs and the fructans, like you alluded, which I think is incredibly empowering, in that if you had a positive response to gluten-free, it doesn't mean you should be gluten-free in perpetuity. I'm assuming for most people, it means that you're reducing FODMAPs and improving from that. And also, when you look at one of the biggest meta-analyses on NCGS or NCGS, non-celiac gluten sensitivity, by Volta and colleagues at Bologna, the distribution in that cohort of IBS is something like 45%. So that tells us that the reactions to gluten are very tightly tied with IBS, and a lot of IBS seems to be FODMAP intolerant, which is temporary. And I think it's a really important conversation for us to start having, because if nothing else, tying in the underweight person that you talked about, who's maybe overly avoidant, now they can start opening up their diet, going out to dinner with their spouse, or eating a slice of cake at a wedding, whatever. I'm not saying go eat Twinkies and junk food, but certainly just open up to non-processed or minimally processed grains when appropriate.
I agree. I think the overlap between non-celiac gluten sensitivity and IBS, is huge, and whether they are separate conditions, I think is, a subject of debate, shall we say.
Okay, so coming to glutamine, I think her name is Gigi. I might be mispronouncing that. Gigi Zhao at Tulane. Camilleri put this on my radar screen. The randomized control trial 2019, 15 grams per day of glutamine, reducing IBS symptoms and normalizing a test for leaky gut lactulose mannitol. Thoughts on glutamine?
Yes, I mean that study's an interesting trial. It's a randomized trial, but it's got mechanistic elements to it.
But it is only one, right? So,
It's the only trial, I think, of glutamine, yes.
right.
And what I found interesting when I read that trial was the response rate, or the difference, the delta, the therapeutic gain of the glutamine over the placebo was massive. I think it's about a 60 or 70% gain over placebo, which is unusual, I would say, in an IBS trial. I think the placebo response rate was about, I can't remember if it's 10 or 15%, and about a 75 or maybe even 85% response rate with the glutamine, which equates to a number needed to treat of less than 2, which is very low, which would mean glutamine is probably one of the most effective treatments for IBS we've ever seen. So again, that probably goes back to my earlier point about small trials by single groups of investigators will often show an extreme or an exaggerated result. It may be that glutamine is effective in IBS, but we would need bigger trials, I think, and more trials. I know that some people seem to use it in people who've got post-infection irritable bowel syndrome. That seems to be one of the groups that the hypothesis is that it would work in the best. So, but I have no experience of using glutamine supplements in my own practice. I don't know about you.
We've been using it in one formula at a lower dose, and then based upon Zhang's trial, we've been making some reformulation attempts with this formula that we use, and we've also been adding glutamine. And I actually personally, in light of that study, tried upping my glutamine to about 15 grams per day. Maybe I've seen a benefit. I can't say I had a lot of symptoms to begin with, so I'm a tough subject. But we'll see. I'm open to it, and we're going to start trying to put that more under the microscope to see what sort of signal we can obtain. I wanted to ask you, kind of as we move to a close, if people have gone through a lot of what we on the show and we also touched on today, the frontline fundamentals, diet, lifestyle, mindset, maybe trialing a probiotic, peppermint, perhaps glutamine, and you're not getting anywhere. It sounds like amitriptyline might be one of the go-tos that you would advise someone to speak with their doctor about. But when these more conservative measures fail, where would you recommend people start thinking about discussing a medication or any other intervention with their GI? Because I think some people have gone to their GIs and they might feel like they get a little bit of a flippant response. It's one medication or the other, or you're crazy. I'm
Yeah.
stereotyping here, but I
No,
think
no.
some people feel that way. So to
Yeah.
speak to that, what should people know?
So I think if people have persistent symptoms that haven't responded to any treatment, then I think it's always worth just rechecking that this is IBS, because things can get missed. So, it's not everyone will have had their celiac serology checked, for instance, and that's something we should do in everyone who's got IBS type symptoms. But I bet, there'll be 10% of people who don't get their celiac serology checked. If someone comes back to me and their symptoms are not responding and they're really debilitating, I would go through everything again. I don't mean I'd go through everything again in terms of investigating them to the hilt, but I would talk to them about their symptoms and I would think about the possibility of a misdiagnosis of an organic condition. So one that I always look out for is bile acid diarrhea, because that is something that is treated much differently to IBS. And I mean, I know this is difficult in a US context because you don't have the test that we have to diagnose it. We have what's called a CCAT scan, whereas in the US, you have to do like a stool collection for fecal bile acids or a therapeutic trial of a bile acid sequestrant. But if a patient's telling me that they've got diarrhea, so it has to be a patient with diarrhea with IBS, and they're going like 10 times a day. To me, that's quite high for a patient with IBS. That's really the severe end of the spectrum. So I would revisit the diagnosis and just say, is this definitely IBS? Did I definitely check their celiac serology? Should they have a CCAT scan? Because I think it's the ones with diarrhea, patients with diarrhea, who you're more likely to miss an organic diagnosis in, and that's important to consider. But to your point, which was really about how do I approach managing those patients, and I think that's where it becomes very difficult. And I guess if you're a primary care provider, then and the person has not had a response or any benefit with first line treatments, then obviously I'm biased, but that's when I would be saying, hey, look at the results of the Atlantis trial. You should be using low dose titrated amitriptyline as your next treatment. But in secondary or tertiary care, where it's likely the patient will have already tried those, all the first line treatments and maybe also tried amitriptyline, then I'd probably go down a route of trying to work out what the most troublesome symptom was for the patient, and trying to pick a drug that might help that. So, for instance, if pain is a real issue, then maybe I'd think about using like a drug like an SNRI, which is another type of antidepressant, but at low dose. So a drug like duloxetine, which has got evidence from other chronic painful conditions for its use. The next stage, really, after for the patient whose symptoms are resistant or refractory to medical treatment, would be to consider use of a gut-brain behavioral therapy. So this would, or sorry, brain-gut behavioral therapy. So again, this is a sort of newer terminology. It's what we would call a psychological therapy in the old days, but we've again reframed these treatments as brain-gut behavioral therapy. So by that I mean a treatment like gut-directed hypnotherapy or acceptance and commitment therapy or CBT, so cognitive behavioral therapy. Now, again, a bit like with using something that's viewed as an antidepressant in IBS, using CBT, which is a treatment for depression in IBS, may seem stigmatizing, but I'm talking about specific forms of CBT that have been designed for use in IBS and that have been shown to be effective in IBS in big studies. So there's two big studies, one from the US, from Jeff Lackner's group in Buffalo called the IBSOS study, which used CBT. It was funded by the NIH, and a study from the UK called the ACTIVE study, which was funded by the NIHR from Hazel Everett, who's a professor of primary care in the UK. And both those studies have shown a benefit of IBS-specific CBT, both delivered in person and delivered remotely, so over the internet and over the telephone, over an educational control or a treatment as usual control. And actually, in Hazel Everett's study, they've completed long-term follow-up in that study out to 2 years, and the CBT arms have still got a benefit in terms of their global symptoms over the treatment as usual arm. So I think there is a lot to be said for brain gut behavioral therapies in IBS, and actually I would argue maybe we should be using them earlier on in the natural history of the disorder, not as a kind of last gasp sort of backstop when all else fails, because I think they can be life changing for some people.
I would agree. I would second that. In the clinic, we've been using two apps to make it easy for people. One is called Clarity. It's just sort of general CBT. The other is Zemedy, which is one of the apps that had a paper. Although we recently saw that disappear from the app store. So I don't know if they're revamping it or if something happened with Zemedy. But for some people, to your point, especially those who tend to catastrophize, I ate a food, I'm having bloating, and now I'm going to that fear-mongering YouTube video where the person said bloating means there's inflammation, and inflammation's upregulated for 6 months, right? Like the people who have that negative snowball, I think these therapeutics can be super helpful for the sort of brain-gut directed therapeutics. One or two other follow-ups. On amitriptyline, I'm picturing people maybe having had tried amitriptyline and saying it worked, but I didn't want to be on an antidepressant, so they stopped. Do you have any indication if this might be a subset of people wherein they were looking at it as lifelong palliative care instead of considering it as maybe 6 to 12 months reparative, and then they could stop? So they discontinued too early before they hit that sort of therapeutic time interval that was required. Do you have any suspicion that this is I'm sure it happens, but that it might be a decent subset of people where they just abandon the therapy too quickly?
A really good question. So one of the things was we were quite pragmatic in the Atlantis trial. We allowed anyone to come into the trial provided of any subtype of IBS, provided they'd already tried first-line treatments. So we would have included people who'd previously tried amitriptyline in the trial. And there were people who had previously tried amitriptyline in the trial. It wasn't an exclusion. And interestingly, what we did in the trial was we measured endpoints at 3 months, 6 months, and 12 months. And at 3 months, the effect of amitriptyline for global symptoms was significantly superior to placebo, but the effect for abdominal pain at 3 months was not. There was a signal that it was more effective, but it wasn't statistically significant. But at 6 months, amitriptyline was superior to placebo for global symptoms and for pain. So I think the message really is that, certainly for pain, you may need to take 6 months or more to have a benefit of amitriptyline or another tricyclic antidepressant. I don't think 3 months is long enough. So I would urge, as long as the treatment's being tolerated, then it's fine to continue it and to even up titrate to from 10 to 20 to 30. Some people would say go beyond that up to 50 milligrams a day, but we didn't study that in Atlantis. Other people say, amitriptyline is not very well tolerated. Well, we didn't really see that in Atlantis. Most people continued the drug. There were fewer discontinuations in the amitriptyline arm than the placebo arm, although of those who discontinued in the amitriptyline arm, more discontinued because of side effects. But an alternative to amitriptyline, if you're concerned about side effects, is to use a drug like nortriptyline, which is within the same class of drugs, but it's a more recent drug and it has fewer side effects supposedly. So you can use that in an identical way, same titration regimen, and for the same length of time. So yeah, I think you have to wait for the benefit. I don't think it's going to happen within a couple of weeks or even necessarily within 3 months, although it might do.
Right. Well, no, I'm glad I asked that question because this is something that in a few of the trials, most namely on constipation, this is using probiotics, they didn't see improved regularity until 3 months or later. And so that got me being a little bit more cognizant of the time to reevaluate the efficacy of a therapy. The other thing I wanted to circle back to was celiac serology. Another concern I have amidst many in my field is sort of sloppy diagnosis. And this is where I see people doing the HLA genotype testing, DQ2, DQ8, and then saying, oh, you have the gene, therefore you're celiac. I don't know of anyone who really gets behind that position, but I'd love to hear your thoughts on what people should or shouldn't do if they're trying to confirm the diagnosis. And of course, they can ask their GI this, but just to preempt, again, what I think my version of or field within healthcare is not doing well, it's a little bit too willy-nilly to diagnose someone with a lifelong avoidant diagnosis and not going through the circumspection of making sure it's actually valid diagnostic criteria.
Sure. So I think, if celiac serology is negative, then it's very unlikely you're going to miss celiac disease. The specificity of the test for celiac disease is in the high 90s. Sorry, the sensitivity of the test is in the high 90s. So if you've got celiac disease, it's likely the test is going to be positive. Now, obviously, that depends on the fact that you're actually consuming gluten at the time that the test is done. And so the problems usually arise where the individual has already excluded gluten from their diet before they have a test for celiac disease, whether that be a blood-based test, so a tissue transglutaminase, or whether it's a duodenal biopsy. So, if you want to make sure that you've effectively ruled out celiac disease, the best way of doing that is to be on gluten and to have a serological test performed. If you are not on gluten and you're on a strict gluten-free diet already, you'll get a negative test. I mean, you could argue it's unlikely that anyone's diet without the help of a dietitian would be strict enough for some gluten not to be creeping in, but I think who knows is the answer. So I don't go down the route of HLA testing for someone who's got negative serology. I think if there's a kind of converse situation. So if you have a positive serological test, it's likely you're going to have an abnormal duodenal biopsy. Now, whether that be either raised inflammatory cells, what we call intraepithelial lymphocytes, or villus atrophy, it's going to be one or the other usually. And that will mean you're likely to have celiac disease. If you've got villus atrophy, you have celiac disease. If you've got raised intraepithelial lymphocytes, then it's probable you've got celiac disease, and you will probably develop celiac disease if you don't go on a gluten-free diet. But sometimes you'll see the converse where someone does duodenal biopsies for another reason and they show raised intraepithelial lymphocytes or partial villus atrophy or something like that, and yet the celiac serology is negative. So that could be because the patient has, an immunoglobulin deficiency, and the serological test is an IgA, immunoglobulin A test. And then you're left in a bit of a limbo as to, is this celiac disease? So, you could do some IgG based anti-gliadin type antibodies to see if they're positive, although they're not as sensitive and specific, or you could then get into the kind of HLA testing. But many people, normal people who don't have celiac disease, will have that particular HLA DQ2 haplotype.
Right.
So it's not it's not a diagnosis of celiac disease by doing that. So for the average person with IBS, provided they've not got IgA deficiency and they're eating a normal gluten-containing diet, if celiac serology is negative, that's it basically. They haven't got celiac disease in my view.
Right. Right. Okay. Okay. Well, Alex, this has been a great conversation. Is there anywhere you'd want to point people, a website, or I'm not sure if you're very vocal on anything like Twitter or social media, but if people said, smart guy, where can I learn more from him? Where would you point them?
So I do have I am on Twitter. I don't have that many followers, about 1,500, I think. But the Twitter account is kind of personal as well. But I do tweet my own research from there. So whenever we publish a paper, I usually tweet from my from my Twitter account. I'm on the University of Leeds staff homepage, so you can look me up on the University of Leeds, and you'll be able to find out, a bit more about me, my research interests, and my publications are on there as well. And obviously things like Web of Science and Scopus, you can look me up there. So yeah, I don't have a Facebook page or Instagram. I'm a bit too long in the tooth for those.
Awesome. Well, Alex, thank you again. It's been a really wonderful conversation. Appreciate you taking the time.
It's been great talking to you, Michael. Thank you very much.